Good morning, everyone, and welcome to what poses to be an excellent final scientific session of the 2021 annual meeting. I'd like to introduce Dr. Carla Scott, who's going to speak on selective versus routine spinal drainage use for fenestrated branch endovascular aortic repair from her colleagues at the University of Texas Southwestern Medical Center in Dallas. Dr. Scott, go ahead.
Selective versus routine spinal drain used for fenestrated branch endovascular aortic repair. These are our disclosures. Fenestrated and branch EVARs have emerged as a new treatment option for complex aortic aneurysms, and it is considered a safe and effective alternative to open repairs, with lower perioperative morbidity and mortality. Paraplegia remains one of the most devastating complications after open and endovascular repairs of thoracoabdominal aortic aneurysms, with rates ranging from 3.8 to 13.2% in open repairs and 4.3 to 14% in endovascular or hybrid repairs. This demonstrates that the rates of spinal cord ischemia did not diminish with the migration from open to endovascular repairs. The mechanisms that causes spinal cord ischemia still needs a better understanding, and nowadays are thought to be spinal cord infarction secondary to low perfusion pressure, reperfusion injury after transient periprocedural low perfusion, and microembolic trash arising from intra-aortic manipulation. How to prevent this devastating complication? Nowadays, there are different modalities that demonstrated their value on assisting surgeons to prevent spinal cord ischemia, like prophylactic cerebral fluid drainage, neuromonitoring, hypermissive blood pressure, preservation of collateral pathways as much as possible, and stage repairs. Even though cerebrospinal fluid drainage is widely used, its benefits remain unproven, and recent studies have demonstrated that maybe the complication risk is greater than the benefits. For example, in this recent systematic review that included patients undergoing thoracoabdominal aortic repair, the rate of any reported cerebrospinal fluid drainage complication was 9.9% and 2.7% for severe complications. Those complications ranging from minor post-procedural puncture headaches to potentially devastating problems. In this other study by Dr. Aldrich, cerebrospinal fluid drainage-related complications were assessed in patients undergoing first stage or completion fenestrated branch EVARs. They reported up to 10% drain-related complications, being 4% severe complications, including intracranial hemorrhages and spinal hematomas. Some surgeons developed spinal cord protection protocols that does not involve prophylactic cerebrospinal fluid drainage. Moreover, this study demonstrated that selective staging without prophylactic cerebrospinal fluid drainage contributed to a significant reduction in the incidence of spinal cord ischemia. The role of spinal drains for fenestrated branch EVARs has not been demonstrated. And given the potential for serious complications related to cerebrospinal fluid drain, the risk of prophylactic cerebrospinal fluid drainage should be carefully weighted against its potential benefits. But still, in selected cases, spinal drains are used to ameliorate spinal cord ischemia. So the aim of this study was to assess the outcomes of spinal cord protection with and without the routine use of spinal drains during fenestrated branch EVARs. This was a single-center study that included 145 patients submitted to fenestrated and branch devices with custom-made and off-the-shelf T-branch devices. The primary endpoint was the frequency of spinal cord ischemia. As part of a spinal cord ischemia prevention protocol, all patients had perioperative neuromonitoring with NIRS, and the patients that had at least one of the hypogastric arteries occluded or planned graft that would cover a segment greater than 30 millimeters above the celiac The somatosensory and transcranial motor evoked potentials were added to the neuromonitoring. The systolic blood pressure goal was 140 to 160, or a mean greater than 90. Whenever was possible, it was planned to preserve as many collateral vessels as possible, but when the patient presented a high risk for spinal cord ischemia and a high segment that would be covered, stage repairs were performed with 2 to 3 weeks prior to the index procedure, and the surgeon tried to reperfuse the lower extremities as soon as possible based on neuromonitoring. Here are our results. Most patients were male, 72%. The median age was 70, and the mean aneurysm size was 58.5 millimeters. Out of the 145 patients in the study, 6% had an endovascular repair extend to zone 2, 20% extend repair to zone 3, 18% to zone 4, and 61% extend repair to zone 5. We use patient-specific devices in the majority of the patients, being the most prevalent the fenestrated devices, corresponding to 71% of all devices used, and off-the-shelf T-branch devices in 17% of the patients. As previously reported by another study, stage repair significantly decreased the risk of spinal cord ischemia after fenestrated branch EVARs in our study as well, with a reduction of 80% in the frequency of spinal cord ischemia. Prophylactic spinal drain did not demonstrate association with the decrease of spinal cord ischemia, and a high implantation zone was not associated with the increase of spinal cord ischemia. This is the demographics of the entire cohort, and the only history of stroke demonstrated to be statistically significant between patients with and without spinal cord ischemia. This is the description of the patients that had spinal cord ischemia. As demonstrated, the majority had minor motor deficits. In conclusion, fenestrated branch EVARs can be performed with a minimal risk of spinal cord ischemia without the need for routine prophylactic spinal drains. High implantation zones did not predict spinal cord ischemia after fenestrated branch EVARs. Stage repairs significantly decreased the risk of spinal cord ischemia after fenestrated branch EVARs. Future studies and randomized control trials are needed to define the role of spinal drains during fenestrated branch EVARs. I would like to thank again the VESS for the opportunity to present our study. Thank you.
Thank you, Dr. Scott, for a very well presented series, and congratulations to you and your co-authors for bringing this to our meeting. As the questions come on the chat, I'd like to start with a couple of thoughts. Your second and third conclusion points, that the high implantation zone in your series you did not find correlated with problems. Then your third point is that stage repair protects you from that. Maybe those two things are counteracting each other because you're not doing it in one stage. And so I wonder statistically how you decided which ones to stage, and if the high implantation zones were all the ones that were staged, and that's why you didn't see that as a predictor for spinal cord ischemia. I wonder if you have comments on the number of patients that got staged, and then whether that's then the reason why the high implantation site doesn't become paraplegic.
I prefer to defer this question to Dr. Carlos Timaran.
Thank you, Jason, and thanks for the opportunity to share our experience with you. You're correct. You know, this series has been, developed over the last 4 or 5 years. So we have routinely used staged repairs as part of, all the patients that we include in our ID study. So you're right, you cannot separate staging versus no staging. All we did is try to compare those patients in which we did not do staging because we thought that they needed to have all the repair at a single setting, but the vast majority did have staging. So I don't think we can separate those two things. And based on that, we cannot conclude that probably the external repair per se is not affecting the risk of spinal cord ischemia. Maybe it would be different if we were doing the repair in one stage. Having said that, I just don't think that endovascular repair has the same kind of effects on the spinal cord perfusion as open repair, because it's a totally different type of repair. We maintain flow throughout the repair. Obviously, we don't reimplant intercostals, except in very few cases. But the main and the most important part of all this is that the hemodynamics are totally different. So based on that, we think that the external repair may not be as important. More important, the spinal cord ischemia does not happen early on. As you saw in the table, well, I guess it was kind of quick, but most of the spinal cord ischemia cases happen after 48 hours. That's where we believe that the prophylactic spinal drains does not work, because it will not prevent most of the cases. Most of the cases happen afterwards.
Okay, thank you. We have some questions from the floor. Dr. Jeannie Ruddy wants to know how the neuromonitoring methods that you described several of, which ones you've settled on, and how that influences intraoperative decision-making. Does that stop you from finishing off the final branch, the final fenestrated branch, and how this monitoring winds up affecting sort of the overall time of the case and the conduct of the operation?
Yeah, that's a very interesting question. We actually try different things. We did try the branch occlusion testing with balloons, just to see if we needed to leave one of the branches open, what people call sac perfusion branch. And we found that that's probably not necessary in most cases, because we always have some type of endoleaks in these cases. And we have been able to assess that using contrast-enhanced ultrasound at the end of the procedure. Actually, Carla is who actually has developed that protocol. So we do contrast-enhanced duplex scans at the end, and we see that most people have some sort of perfusion, whether it's through the grad material or through the holes of the containing sutures or wires. So I don't think that leaving a perfusion branch open really changes much. We used the neuromonitoring routinely for a while, but we didn't find that actually help us. Maybe the NIRS is more important, not necessarily to tell us who's going to develop spinal cord ischemia, but actually to tell us how the perfusion of the spinal cord is being affected by what we're doing. And also, more important than that, it guides us to actually maintain a blood pressure that's optimal. See, we always thought that keeping the blood pressure way up was better, but we don't think that that's true, because we had some instances of strokes related to hypertension. So instead of now pushing the blood pressure all the way up, we assess with NIRS what kind of perfusion we need, or blood pressure we need to maintain perfusion.
Okay, and then very quickly, Max Wohlhauer wants to know how many patients had, or how you sort of plan it out when they've had prior aortic surgery, either endo or open, maybe a completely replaced infrarenal aorta or a proximal TEVAR that's already been in there.
So that's important, Jason. We don't change what we do based on that. We don't add spinal drains to those people, but I have to say the spinal drains are still used for those people that have what we call incomplete networks. One or two occluded, hypos, or subclavian, left subclavian that's occluded, or vertebral occluded. Those are the people that still would use spinal drains for prophylactic.
Okay, and then finally, Matt Corrier wants to know, you mentioned perhaps a randomized clinical trial. Do you think a patient would really accept a drain or no drain while they're already deciding on complex thoracoabdominal endovascular repair?
Yeah, it'd be hard. First of all, we need a good number, a good sample. We have the Aortic Research Consortium. All the people that have ideas in the US have established this consortium, and we're working on trying to get a randomized clinical trial. It will be hard because some of us had actually switched to not using drains. So go back to using drains may be a problem for some of us. Others don't believe that, we can do that without drains. So convincing first the operators and then the patients to do all these on top of using investigational devices, it becomes a little difficult. But I think we can try and see if we get any results from that.
Well, thank you, Carlos. We look forward to getting more results from you and your team over the years.
Thank you.